Okay, so Linda's already told you that we give out lots of questionnaires, and I'm constantly encouraged and amazed that the patients fill them in, because it does take you about 20 minutes or half an hour to fill them in. And so we measure pain, as you might expect. We measure acceptance, fear avoidance, beliefs, disability, anxiety, and depression. What I'm going to show you is the difference between their scores on those measures when we met them at assessment and all the way through to when they've completed the program and the 6-month follow-up. There's no control group. This isn't an RCT, but given that the average length of pain for our patients is, when they start the program, is 10, 11 years, I think spontaneous remission here can be pretty much ruled out, although some people, of course, will still get better. So we give them 4 numerical rating scales measuring their pain at the current moment in the past week, at its worst and at its best. And these are our outcomes. We don't make any difference to current pain. Hardly surprising, all kinds of things affect current pain, including which way the wind's blowing. We wouldn't expect to change that. What is encouraging is that we do make some improvement on their pain in the past week, and that improvement seems to be maintained 6 months after they've completed the program to a large degree. These aren't huge changes, but I think it's probably fair to say that a lot of the drugs aren't making huge changes either. So pain in the past week seems to improve, which is probably likely to be if we're helping people to approach their activities in a graded way, avoid overdoing things, be more aware of their body, not pushing themselves into flare-up. And that also probably explains why their worst pain is slightly better as well, and again that's maintained. These are quite powerful analyses. I think for the post-group one we're talking about 400 or odd patients over the years, and then probably 300 and 200 as people drop out over the time. We don't make any difference to their pain at their best, but again I don't think that's very surprising. That's when things are all going swimmingly. So we make some changes, and probably ones that we would predict to people's pain, but they're not massive. They're nothing to get excited about. We definitely very much aim to change people's acceptance of pain, and this is a kind of snapshot of the chronic pain acceptance questionnaire. And you can see it's got items like it's okay to experience pain, I'm getting on with life no matter what my pain is. So you can imagine that people who endorse that are doing better, have a different attitude to their pain, less fearful, less deterred by it. And we make a huge difference to this, to be honest. 15-point differences, and these are maintained completely across the follow-up periods as well. And patients talk about being more accepting, being less pushed around by their pain. We've mentioned how important avoiding things and fear of pain and fear of damage is. There is a measure with the lovely name of the Tampa scale for kinesiophobia. Sounds very Americanly impressive, technical and scientific. But yeah, fear of movement. And you can see that some of the items there, although they're not that clear, I'm afraid I might injure myself if I exercise. If I were to try to overcome it, I'd just get more pain. My body is telling us something dangerously going wrong. And you can see how that would put people off doing things. And we take a big chunk out of that as well over the course of the program. And those improvements in people's fear and improvements in their confidence seem to be maintained over our follow-up periods as well. There's loads of measures of disability out there. I don't think I'm satisfied with any of them. They often kind of measure how people's function is, and that's not necessarily a measure of how much pain they're in, but all kinds of other social things. The Oswestry pain questionnaire, the Oswestry Disability Index, has 10 areas of life, and it asks about restrictions in those, and it gives you a percentage score. Immediately after the group, they seem to be significantly less disabled, but we don't maintain that one, and we're a bit dissatisfied with that. We have started looking at measuring movement more, uptime, and we're thinking about strapping some some monitoring devices onto our patients to see what they're actually doing when they're not with us, and I think that might give us a clearer picture. But we're a bit disappointed in that. You'll all be familiar with the HAD scale. There are issues with that as well, but it's probably one of the better ones we have that is less polluted by health problems. And unsurprisingly, we do okay with that. We reduce people the average from being a definite case for anxiety to a possible case. But for some people, there's big differences in that. They go from people who are terrified all the time to completely in the normal range. And as you say, with those differences, they seem to be maintained as well. And it's the same story for depression as well. We take a bite out of that. And again, that seems to be maintained. I'm particularly pleased in how well most of these outcome measures seem to persist. And you would argue that if it's a self-management program, we've given people all of this information and skills and techniques and so on, then you would hope that they would continue to use them. But I'm encouraged about how well they seem to do over time. They're the questionnaires. We also give patients a feedback questionnaire as well, where they can write away to their heart's content and write comments on various aspects of the program. These are just some of the comments from our patients. A bit of selective reporting, but it's nice when you hear people talk about things that in the way that the theory predicts that they should talk about them, about pain being putting it in its place, and it being just a feeling and not something that pushes you off course, and about people doing more. And about realizing how all of these complicated things, that biopsychosocial model is complex, and it does take patients a while to kind of fit all the pieces of the jigsaw puzzle together, but we usually do find that it is about midway that there's a kind of light bulb moment going on for patients, and they realize why all of the different aspects are worthwhile. And finally, I did something else as well last year, which is I thought if you've been through the pain management program, then you're likely to be an expert on pain self-management. And so we asked 60 of our graduates what they wished they'd known earlier in their pain career. Now, as you know, we have all these patients coming in, and they're coming to see you as well, and they're desperate for a cure. Show me some technology. Surely there's an operation. I need some more investigations. And perhaps the most gratifying thing is that the role of surgery and injections gets relegated to last place. What they do say is important and kind of vindicates our approach, I hope, is how important thoughts and feelings are, understanding how the pain system works, having a better grasp of what the medicines do. An awful lot of them are fearful of the medicines or take them inappropriately, as you are well aware. They see the importance of pacing their activities. Working on sleep is another thing we do. But I intend to give this same questionnaire with obviously slightly different wording to naive new pain clinic patients and make the contrast, and I'm expecting the results to turn out quite differently. So in summary, I think we do things to our patients. We don't reach all of them. They are a difficult group of patients, as you're well aware, to change. They get entrenched and stuck in attitudes and habits. But I think some of our outcomes there show that we're moving them in the right direction. So thank you very much. If anybody wants to get in touch and ask about particular patients or anything, I'll give you our email addresses. Feel free to email us. We'll answer queries, and I think we'll take some questions now, if anybody has any. Thank you.